And welcome everybody this morning to the West Yorkshire Joint Health Oversight and Scrutiny Committee meeting. It's a while since we'd had one. Can I ask everybody to, if they could mute their while I am, and if only if you're speaking, if you could have your microphones on. Just a couple of housekeeping before I start. And that's one of the things, if we could have if members of the board could have their cameras on, but until you're speaking, to have it on mute so that it minimises background noise. Also, if we could have if you want to raise a question, if you're able to raise your hand or do the raise hand icon so that I can make a note of who wants to speak. If you're unable to do that, if you could put into the chat that you want to speak, I can pick you up that way as well if you want to make, if you want to do a question that way. Is there any other housekeeping, Mike or Carol, that I need to mention to members of the board?
I don't think so, Chair.
Okay, thank you very much. So you're all very welcome, and we are live streamed on YouTube, and you're all very welcome here today. And welcome also to our partners. And if we could go through the first items on the agenda, and first of all, I'd like to welcome people. If I could welcome people on the board, please, first, and then as we come to the different items, if partners from NHS and other partners could introduce themselves, then that would be great. So my name's Helen Hayden. I'm councillor on Leeds City Council for Temple Newsome, and I chair the West Yorkshire Joint Health Scrutiny Board. So if I could go to, have we got Councillor Soloway? Okay, if we go to Councillor Whitehouse. Councillor Smage, would you like to come in and introduce yourself?
Thank you. Councillor Smage from Kirklees Council, member of the panel. Thank you.
Thank you. Councillor Hutchinson.
Councillor Hutchinson from Calderdale Council, member of the panel.
Thank you. Councillor Baines.
I'm the other member of the panel from Calderdale Council.
Thank you very much. Councillor Latty.
Good morning, Councillor Graham Latty from Leeds City Council, the member of the panel.
Thank you. Councillor Greenwood.
Hi, Councillor Greenwood from Bradford Council.
Thank you very much. I don't think we've got, I'll try again with Councillor Soloway. Can you hear us, Councillor Soloway? You seem to be in the meeting. Okay, well, hopefully we can, if somebody could see if he can hear us and can access the meeting, that would be great. Thank you very much. So it seems a very long time since we've had a meeting of the board, and it seems that it's an awful lot happened. In fact, the world has completely changed since we were last here. So obviously, in terms of public deputation, we normally have people wishing to speak, but if it can be that, obviously that wasn't possible. So can I ask if we've got any other, if we've had any responses from anybody wanting to make a deputation, if those could be read out?
We're not aware of any, Chair.
Okay, thank you very much. Can we look at the minutes of the last meeting, please? Were they they were sent out. And it's, as I said, it's a very long time ago, but can I take those as a true record? And if I take silence as a true record, please. Thank you very much. Okay, so if we come on to the first agenda item, and I'd like to also welcome anybody who's watching the meeting. But if we go on to the first agenda item 8, which is, oh, sorry, I've forgotten to do apologies. So Mike, we've got apologies from Councillor Whitehouse, have we?
That's correct, Chair. Yeah.
Okay. So if we go to go to the first agenda item now, please, which is the ATU, the ATU units, and this. So we've had the report through. Oh, sorry. Yes, item number 6, assessment and treatment units, an update. So we heard about this at the last meeting, and in February 2020, it was agreed that we would start further public engagement on the proposal to close the Leeds unit and provide a regional service from 2 generic units based in Bradford and Wakefield on 2 of the 3 current ATU sites. This proposal was shared with the Health and Wellbeing Board chairs, council leaders, local overview and scrutiny committee chairs, and the West Yorkshire JOSC. So this report provides an update for the joint health scrutiny committees from the last discussion in February 2020. So can I ask who's going to speak on this report?
So that will be me.
Lovely, thank you, Andy.
Thanks.
So if you'd like to introduce yourself, and we've, as Mike sent out, if you could speak on it for about 5 minutes. And obviously the world has completely changed since February 2020. And I know from Dr. Sarah Monroe that, you know, it's been quite a trying time, and that things haven't gone as you would have wanted it to go. So if you could update us all, and then we can take questions, I'd be really grateful. Thank you.
Thank you. So I'm Andy Weir, I'm the Deputy Chief Operating Officer at Leeds and York Partnership Foundation Trust, but I'm also the SRO for the piece of work, the ATU reconfiguration work across the ICS footprint. So really the purpose of coming back today was to provide an update, and that update is twofold. Since the paper was written, there's been a change in terms of ATU provision in Leeds. So as is set out in the paper, originally, in response to COVID, we relocated the assessment and treatment unit in Leeds from a building that was previously Parkside Lodge to the St Mary's Hospital site. And that was a temporary relocation, and the driver for that was simply to create some COVID cohorting capacity in our older people's unit, which clearly was necessary. Subsequent to that, there have been some environmental issues with that relocation, and there have been some clinical concerns in relation to delivery with that, in relation to that relocation. And so we made the decision 2 weeks ago now to temporarily suspend delivery of the assessment and treatment service in Leeds. This is a temporary closure of the service whilst we think about what to do next in terms of both this work and also in terms of the environment in which the service currently sits. So that's an update to the paper. In terms of the work, though, you'll recall that last time we came, we presented a plan which was about lots of very direct public-facing engagement, going out and meeting groups of people and bringing people together to talk about the future service model, etc. And clearly, exactly as you described, the world's changed quickly and significantly. And we have, although we've continued with the ATU work, and we still have a multidisciplinary work stream from across the provider organisations and commissioners, we're clear that actually our original plan in terms of that engagement is now not deliverable in terms of social distancing and all of the other COVID issues that arise. So we've revisited that. And essentially our plan now, it's really important that we carry on doing that work. So there's no suggestion at all that we don't want to do the engagement, but actually our plan now is to do some very targeted engagement, and that's around individual one-to-one conversations with people who use the ATU services across the footprint, with their families particularly and their carers, and also an identified cohort of people who use our community learning disability services who are potentially at risk of being admitted to ATUs in the future. So we've identified essentially a smaller group of people. We're still going to do some online engagement work, but that's limited, frankly. And so essentially, well, what we're saying today is we want to carry on doing the engagement work, but it will be shorter and it will be more targeted than we originally proposed. I think the outcome will be the same. And I think, you know, I'd wish to reassure you that we are absolutely clear this has got to be an engagement piece where we understand the consequences of the proposed future model. You'll remember that last time I talked about the engagement work that we've done up until now, which was significant, particularly around carers. But I think that there's still more work to be done. So that's where we are. The work is ongoing. The paper sets out, there are 4 work streams, all set to deliver shortly, particularly an overarching governance framework so that we can see in the new proposed model how we're going to be sure that the services are delivering what we want them to deliver, and that we continue to make them better. And our aspiration, of course, is absolutely about developing a centre of excellence across the West Yorkshire and Barnsley, in this case, footprint, in terms of delivering inpatient care for people with a learning disability.
Thank you very much. Has anybody got any questions at this point for the ATU team or for Andy? Okay, obviously, oh yes, Councillor Smaid.
Yes, sorry, I'd used the raised hand, sorry. You were talking about the consultation, and I understand that there needs to be different methods of consultation at this moment in time. But we were talking before about community services as well. So it wasn't just about the unit itself, it was about community services working well to take pressure off the units, and so that there's enough service across all the areas that the 2 units would serve. And therefore I'm concerned that the more targeted consultation is just about the ATUs, and there doesn't seem to be any discussion about the community services that would support the ATUs to ensure that there is enough capacity in the system.
So sorry, that's me confusing you, I think. There's a plethora of work going on about the community services in a whole variety of different places. So not least the Transforming Care Programme Board that oversees all of the changes in learning disability services. And we have a clear link, there's a lead for that work. And she sits on the ATU steering group. So I think we talked about this last time, didn't we? Whilst we acknowledge that there has to be lots of change in community services, some of that happens in place and in the different places, and there are slightly different configurations of the community learning disability services in each of the different places. But absolutely, you're right. In order to ensure that correct admissions occur and that people don't come into hospital and stay longer than they need to, the community provision needs to be developing in some places. But it really is. There is a whole load of work going on, but that doesn't sit under the umbrella of this piece of work. It sits in the wider Transforming Care Programme.
I think I'm still concerned that there is just targeted consultation, and that there is not some information going out for people to input if they wish from specific from groups, and other organisations are doing some consultation by methods that are a little bit wider at this moment in time, and I'm just wondering if you've looked at all of those and whether any of them are suitable for you.
I'm wondering if Karen Coleman, our comms lead, could assist. That would be helpful. We just to be clear, we're not saying we are just going to do.
Absolutely not. Yeah. So morning everybody. Nice to see everybody today. Sorry, I couldn't put anything in the chat because it's playing up. So apologies from me. I think Councillor Smaid.
Oh, Karen, I
yes.
did get your chat. Yes, I was just actually, yeah. So
great, thank you.
It's working.
I thought I wasn't working very well today.
No, you're great. It's lovely to see you.
Oh yeah, you too. Councillor Smaid, I think it's really important the points that you've raised, and we haven't absolutely not forgotten the conversation that we had around engagement, because we agreed it wasn't statutory consultation, that it was engagement when we discussed earlier on this year, if you recall. We were all set to go a week before lockdown. We were set to go. We'd got Inclusion North, who was working alongside of us, with lots of engagement in the 3 ATUs via the staff, and ensuring we had that impartiality in place. We then sort of considered, Councillor Smedge, doing something via Zoom or different methods to make sure that we were fully engaging. But we took advice from NHS England, and one of the papers that they brought out felt that at the time it was more relevant to pause that and not to cause any more anxiety and concern. I think moving forward, we absolutely need to ensure that we keep everybody informed, the carers, and that we do a targeted approach on those who was most impacted by any change that we see taking place across West Yorkshire and Barnsley. We haven't forgotten that at all. But what we did want to put forward today was we wanted just to give you a position statement on where the current situation is around the buildings, and also really to ask your views of how we move forward using a much more targeted but a lighter touch approach that doesn't cause anxiety or further concern during these difficult times. In terms of what Andy was saying around engaging on community care, this work for the engagement will be led by the steering group, which feeds into the transformation board. And I do update colleagues who work on the commissioning arm of both adult social care as well as NHS commissioning them integrated roles. And so we will, of course, make sure that we update following the conversation from today and how best you'd like us to move forward. Does that help, Councillor Smedge? A little bit.
A little bit, but I think there's other people that are wanting to ask questions.
Of course,
So I'll let them come
but
in.
we can have a conversation later as well if it helps.
Yeah, I think that would be a good idea. And it would be nice if we're all having to adapt at the moment and how we consult people, but there are ways and means of doing that now. And I know you are consulting with carers and with you know, people who use the facilities, but I think I agree with Councillor Smedge that yes. I think it would be good to get a wider view on this. Can I bring in Councillor Hutchinson, please?
Thank you, Chair. I again would reinforce what Councillor Smedge has said about the breadth of the engagement that's needed. I also wanted to, you know, I understand that it's important to get the views of people who are actually using the units, but I'd like to know how the turnaround of patients in these units is fairly slow. How far back in time are people who've actually made use of the units over the last couple of years or so being contacted? So that was one of my questions. I have a second, if I may.
So our original intent was to go back between 3 to 4 years. We have a current list of people who have used services in the last 3 to 4 years. And our intent was to contact both them and their families directly. We have engaged that list of people once previously. So in the earlier work in this work stream, we sought to get feedback from people who, for a period of 2 to 3 years, had used the service previously. The uptake was low, but we anticipated that, and we think that this time around we will try to do that in a slightly different way.
Okay, that sounds good to me. The other question was obviously one of the main drivers for this reconfiguration was to try and reduce the number of people requiring out-of-area placements. I was wondering, over the past 6 months and the trials and tribulations during this time, what the pattern has been of the use of out-of-area placements.
So we have admitted one patient to an out-of-area bed in the last 6 months. And that was predominantly driven by his clinical needs. He had a set of very complex clinical needs which couldn't be met by our current ATU provision. So actually, the correct thing for him was to find a short-term placement out of area, whilst a longer-term non-hospital placement was found for him.
Thank you very much.
Thank you. Any other questions? I'm trying to scan for hands up and it's very difficult. Can I just ask about how, because Bradford was a particular problem or was experiencing problems 6 months ago, and I don't know whether Councillor Greenwood, you know anything more about the situation. I know that one of the Leeds patients has gone to Bradford, so whether Andy, you can help, because I know that there was some problems in Bradford 6 months ago.
That's right. So when we last presented the work, there were a cohort of people who'd spent a very long time in the ATU. In fact, some of them 2 years and longer. and there was a sense that they were struggling to find correct placement. Through absolutely sterling work between the local authority and the health provider, the majority of those people have now moved on. So actually, that the difficulty that Bradford was experiencing in terms of very, very long-term delayed transfers of care has significantly changed since we last came to see you, which is great news, really.
That is great news. Councillor Greenwood, would you like to come in?
Yeah, thanks for that. Yeah, just so that you know, to make the committee aware, I've been receiving regular updates from the chair of Bradford Care Trust, and the latest one I've received was in July, sometime, I think it was the 13th of July, to say that three people had been moved out, and the rest of them were going to be moving out sometime in July. So fingers crossed, as Andy's just said, they've all been moved out now. So hopefully we're in a good place.
That's great, and that's great work by everybody involved and great partnership work by the sounds of things. So yeah, well done everybody. So, and that gives us more kind of confidence moving forward to two ATUs rather than the 3. So thank you very much. Is there any other questions on ATUs?
I think Councillor Latty has his hand raised.
Oh, did you have your hand raised, Councillor Latty? So thank you, Councillor Hutchinson.
I did, but it's been dealt with, so. Yeah.
Okay. Oh, thank you. It was raised, but then it went down. Lovely. Oh, it's so different anyway. Different challenges chairing a meeting like this. Okay, so thank you very much, Andy. And we will obviously, when things when you recommence the kind of and Karen, when you recommence the consultation at a wider level, and you can come back and tell us how that's gone, you know, later on, and how the new modelling has gone. So really appreciate your time this morning. Thank you very much.
Thank you.
Okay, so if we move on to what will be, let's face it, quite an involved agenda item in terms of what's been happening the last 4 or 5 months. So item 7 is the pandemic update, and those are words I'd never thought I'd say, to be quite honest, but I've been saying them quite a lot recently. So since the Joint Committee met last in public, there's been a significant escalation of the COVID-19 incident, and this necessitated a substantial refocusing of the work in all organisations in West Yorkshire and Harrogate Healthcare Partnership. So this paper is to update the committee on the focus and priorities of the partnership work over the last 4 months and set out focus work for the coming period. So Ian or Rob, I don't know who wants to speak on this first, and if you speak to the paper, and then we can take any questions. I'm sure there will be a few. Thank you.
Morning. Thanks very much, Councillor Hayden. I'll kick us off if you like, and then Rob and possibly Anthony Keeley may come in at the end with some additional information. As you've said, it's quite a brief paper that covers a huge amount of work that's been happening over the last 3 or 4 months, and so I'll take us through it quite quickly so there's a bit of time for questions and conversation at the end. We're keen to give you an overview of what we've been doing as a health and care partnership to support the response over the last 3 or 4 months. We're also keen to get into a conversation about what this means in terms of the work plan for this committee going forward, given that the pandemic will be with us for some time to come. We've also invited Carol Ferguson, who's the Programme Director for the Cancer Programme, and Keir Schilliger, who's the Programme Director for the Mental Health, Learning Disabilities and Autism Programme for this item, because I understand there was some interest in cancer and mental health, so we'll be able to help with those answers, hopefully. So I guess the starting point from a health and care partnership perspective is that there are pretty well established arrangements for dealing with things like this across government. So we've got the West Yorkshire Local Resilience Forum, which is chaired by Robin Tuddenham at Calderdale Council. We've got the NHS Incident Command and Control Centre, which is led down the NHS England route. And those are pretty well established routes, and the ICS doesn't have a formal role in terms of the formal response to the pandemic. But I think what we've learned over the last 4 years or so, and what we've seen in the last few months as well, is that a system response is really, really important on these issues. And I think with some of the partnerships and relationships and ways of working that we've established over the last 4 years, we believe that we can support and add value in terms of the response on the pandemic, recognising that it is place-led and West Yorkshire supported. We've got 3 tests that we apply to everything we do that you'll be familiar with. So is it a critical mass issue? Do we need to work together at scale to get the very best outcomes? Is it a sharing good practice issue? Is there stuff that's been done really well in one place that we can use the partnership to share across other places? Or are there any wicked issues we're actually working on the issue together is likely to give us a better outcome? There's been plenty of wicked issues over the last 3 or 4 months, as I'm sure you're aware. You'll remember that we spent quite a lot of time at the back end of last year working on our 5-year strategy. We published the 5-year strategy in March. That document is still really, really important to us, although the context, as you know, has changed significantly. We've got 10 big ambitions in there, which cover things like how we support Black, Asian, minority ethnic staff, how we improve cancer diagnosis, cancer treatment, how we improve the inequalities that we see across the region, how we tackle issues like mental health and suicide. All those things are probably even more important now than when we wrote them in that plan. So, the way that we need to work will change and has changed significantly, but that direction of travel is still really important as set by the 5-year strategy. Paragraph 6, I think, of the paper sets out kind of a series of phases that we look at, that we think about in terms of the, paragraph 7, in terms of the in terms of the COVID response. We talk about kind of the early part of this year up to April 2020 being the phase 1 response, and this was really around preparing and dealing with the surge that we were expecting. There's then phase 2 and phase 3, which is kind of from the spring and summer through to this year, which is more about thinking about how we restore services, how we meet the needs of people with COVID and with other health conditions, and how we ensure that the system is resilient as possible moving towards what we all expect will be a difficult winter period. In terms of the partnerships phase 1 response, we've summarised that on paragraphs 8 through to paragraph 11 of the paper. We established 4 specific priorities as part of that phase 1 response. The first one was the work that we were doing to support the increase in critical care capacity at pace, recognising that if a surge was going to come at the level that we'd seen in other countries such as Spain and Italy, then critical care capacity was going to be a huge challenge for us. And part of that was supporting the Nightingale development for Yorkshire Number that was located in Harrogate. The second priority was ensuring safe hospital discharge, discharge into the community at relatively short notice. The third one was supporting people who are shielding at home for 12 weeks, and really importantly supporting other groups that we would expect to be disproportionately affected by the impact of shielding and social isolation. And then the final one, really importantly, was how we ensure business continuity and safe services for people who've got pressing and urgent health conditions, which aren't COVID related, but in the context of self-isolation, staff sickness, shielding, and the need to separate services between COVID and non-COVID services. So that was kind of the priorities for that first phase period, as I've said. As part of that, we established a piece of work led by Mel Pickup, who's the Chief Executive of Bradford Teaching Hospitals, around a West Yorkshire approach to coordinating our efforts around personal protective equipment. You'll probably remember in those early days, it got quite, we came quite close to the wire in terms of the availability of personal protective equipment, and actually having a mutual aid approach across NHS partners, local authority partners across West Yorkshire and Harrogate was seen as a really important thing to do to respond to that, and that worked pretty well. We also asked Martin Barclay, who's the Chief Executive of Mid Yorkshire Hospital, to act as the SRO for the work that we were doing across the region around testing and tracing, and that programme of work is continuing as well. The second phase of the response, the second and third phase of response really, because they kind of blend into each other, is from May 2020 through till March next year. And this is really about how we continue to deliver services and meet people's needs in the context of COVID being with us. You know, the expectation is that the COVID, virus will be with us for some considerable time. What we're seeing is localized outbreaks, but a kind of a level of prevalence that continues in the wider population. And priorities for this phase of the response are set out in paragraph 13. The first one is kind of similar to the first phase, which is continuing to provide critical and urgent care for people who've got COVID-19, supporting their recovery and rehabilitation. The second one, really important, is how we restore and provide essential health and care services. What's really clear is that we've built up quite a lot of clinical risk during the first part of this year as a result of people not getting the treatment that they need. Working together to deliver those services that meet those needs is really, really important. Thirdly, and again, this is a continuation from the first phase, is continue to support people who are shielding from the virus, as well as other vulnerable groups. Fourthly, it's around the work that we're doing to keep our health colleagues safe and well during a period that has been hugely pressurized and hugely stressful for them. This includes the work that we're doing around testing and PPE, but also some of the longer term work we're doing around staff health and well-being. Fifthly, and this is the next item on the agenda, is the work that we're doing to really better understand the impact of COVID on different population groups. So the stuff that we know about COVID, it affects older people more than younger people, it affects men more than women, it affects people from Black, Asian, minority ethnic communities more than other groups. There's still quite a lot that we don't know, particularly in terms of some of the indirect impacts and the longer term impacts of the virus and social isolation, particularly on sort of groups that are more isolated. And doing an awful lot of work to try and understand that impact, working with the university sector and public health colleagues. And then finally is the work that we're doing to coordinate the reset to the new normal. So how do we re-establish healthcare services? How do we learn from what's worked well over the last 3 or 4 months? And how do we come up with a set of plans and processes across the system that are really resilient to those localized outbreaks and spikes that will inevitably happen over the coming weeks and months. And that work is stuff that's happening as we speak now. You're probably aware of the letter that came out from NHS England on Friday, which described some of the priorities for that next phase of work. As part of that, you'll have seen that they've de-escalated the incident from level 4 or level 3. What that means is there's likely to be a stronger regional response and greater kind of regional responsibilities in terms of the response rather than national coordination, but a lot of the emphasis that there's been over the last 3 or 4 months will remain. So what this means for the West Yorkshire and Harrogate programmes, as I said, the 5-year strategy and the 10 big ambitions still set the context for our work, recognising that the way that we'll deliver those will need to be considerably different over the next period. Each of the West Yorkshire and Harrogate programmes is constantly sort of iterating and going through processes to test that the work that they're doing is adding value and focus to the system response. We've listed a few examples, of which there's a lot more under paragraph 17 in the paper. So we've done some work, as I've mentioned, with the university sector to better understand the direct and indirect impacts of COVID on different population groups. We've just completed the process of grant funding. We've distributed over £500,000 of grant funding to support population groups most affected by COVID, working with voluntary and community sector organisations. We've done a lot of work to try and understand some of the innovations and good practice that have been initiated in response to the pandemic. And we're looking to work with the Academic Health Science Network to further roll those innovations out. Planned care and cancer programmes are working to support the system response on capacity and planning. So how do we best use our capacity, including diagnostic capacity and independent sector capacity, to get services up and running again to meet people's needs? There's work being led by the Mental Health and Disabilities and Autism programme to understand people's needs from a sort of a psychological support perspective and what the offer might be there. And the carers programmes, we focus significantly around how we support unpaid carers during the pandemic, which is a particularly challenging time for those groups. One of the things that they've done is develop a carer's discharge toolkit. So that's the kind of the summary, really. As I said at the top, we're keen to work with you to understand the priorities going forward and develop that work plan that reflects our work in this context. Rob or Anthony, I don't know if there's anything that you want to add.
Oh, thanks, Ian. That's a comprehensive view. Obviously, those priorities, as Ian's reflected them in each of the phases, are linked to what we knew at the time and what was important at the time. And where we are now is equally as important. Ian reflected that moving from a national level 4 incident to a level 3 incident has happened last Friday. That doesn't mean that we can take any of this less seriously. That's not to do with the seriousness of the incident, it's to do with I guess the geographical spread. So we need to continue to prioritise and focus on things that make a practical difference. And what I would hope that the committee can see is that things we do to make a practical difference. So when we talk about mental health support, we can talk about a 24/7 crisis helpline for the public, which we set up and got running right across West Yorkshire from a standing start. We can talk about the support for people with a learning disability and their families so that they could access services if they didn't know anything about services, and families with autism, for example, deeply impacted by changes to their daily living, and having that kind of signposting and accessing to services has been incredibly helpful for some individuals. You know, putting in place the arrangements around grant funding for third sector organisations. We know from some other work we've done around the health of the third sector that those organisations are very vulnerable at the moment in terms of their income. One of the byproducts of us working together is that we then have a really good, strong set of information about what we could do if we had more money. And we know that the national government is allocating money to the third sector via the National Lottery. So we're now working with the National Lottery to say, oh, here's all of the things that came forward when we asked people what they needed from this £500,000. And I think we're funding 13 schemes, but I think we had about 81 schemes come forward. So there's an opportunity for us to continue to work and build on the good momentum. I think the final thing I would say is that, you know, those practical differences and impact that we've had are down to really strong relationships built in places with really good governance around decision making. And I think that's a testimony to all of the partners, whether it's the third sector or Health Watch or the NHS or local government. I think everyone's played a part in that. And we'll need to continue now to get into this phase of planning for what's going to happen next. And the plans that Ian talked about, you know, the 6 of those priorities that we're currently in around planning for the reset have been stress tested with support from the military around different scenarios. So we're now going to have to continue to be quite agile, depending upon what happens next with this pandemic. And we're seeing over the last week with events in Kirklees and Bradford and Calderdale that different places will be impacted at different times. I think I commend the report to you. I'm just grateful for all the support that all of the partners have given to dealing with a situation none of us have faced before.
Thank you very much, Rob. And yeah, I echo your last comments there about we do seem to have pulled together really well over the last few months. I've got quite a few questions. I think Councillor Smage did put a hand up, did you? And then put into the, so I'm going to start with Councillor Smage, then Councillor Greenwood and Councillor Hutchinson. And anybody else, please either put your hand up or into the chat, or both, if you want. Thank you.
Thank you. I think it's Councillor Clark also indicating. So I've got several questions. I think I submitted a couple of questions already to the officers about cancer services and mental health services. Both now and going forward, certainly in the mental health services, about the suicide prevention strategy and where that is, how people who have mental health problems are being helped going back to school and work, and getting out if they've been shielding to get out. How are people with learning disabilities and autism being held, and what is the strategy going forward into the winter months, and how services can be strengthened to cope with what might be higher levels of problems than we had previously. And on the, I also wanted to ask about dementia services as well in that respect, and on cancer, sort of an overview of where we are, communication strategies to encourage people if they have symptoms to come forward, and how are the hospitals going to be organised in relation to cancer care. I also wanted to ask about the safe discharge to hospital, safe discharge from hospital, and how the partnership have supported that in the past months, and how you are supporting that going forward, because I think we all realise that safe hospital discharge is extremely important. Thank you.
So who would like to answer that?
We take them in that order. It's just, Keir, do you want to come in on the mental health, learning disabilities and autism stuff?
Yeah, that's fine. Thank you. So what I'll do is just a bit of a summary of mental health services per se, and then touch on learning disability and autism. So it's fair to say that across the duration of the pandemic, that our NHS provider mental health services have been continuing to provide the services they did beforehand. So the talk of kind of reset is kind of a slightly strange one to some extent, because the services have still been there doing what they did. Now, it is true though that a lot of adaptation has had to happen. So we've had to undertake more virtual provision than we would have done historically, retaining face-to-face services where that was necessary and where kind of service users required that. And as we kind of touched on earlier on, particularly with relation to the ATU discussion, trying to make the capacity available within inpatient services as a result of the impact of COVID and what that does to our inpatient ward. So there has been some significant changes in practice driven by the pandemic. What that kind of means is that actually kind of despite the kind of challenges that might pose, so kind of the potential reduction in capacity, the kind of the impact of kind of shielding staff, which is obviously true across all health and care services, not just mental health, and the new ways of working, to echo the point that that Rob and Councillor Hayden made, as a kind of collaborative of NHS providers, we've really seen the benefit of being able to share approaches, learn from one another about how we tackle these kind of tricky challenges collectively, and how we provide mutual aid across those providers to support one another as the pandemic has developed. The question about what might happen going into the winter months and where kind of the commitment lies, what is really telling, and this was emphasised again on the national kind of call with NHS England today, is that people may be aware that there is a commitment to increase spending for mental health provision kind of on a year-on-year basis, out with kind of physical health spending through the mental health investment standard. It's really, really clear that expectations are that we continue to make sure that spend flows to mental health services, and there is no reduction in expectation as a result of the pandemic, that the kind of the spend that is expected to move into mental health provision continues to happen. And there is a lot of stuff that we have started to look at as a result of the pandemic too. So Ian touched briefly about what we're looking at in terms of psychological support. So there's a bit of a recognition that in the short and the medium term, lots of our individual places, whether that be our individual NHS providers or some of our BCS organisations, have put in place unique support for their staff and helping them cope during the pandemic, or specific interventions to support some of our more vulnerable communities like BAME communities, and those people who have had COVID and are recovering from it, and trying to understand what the psychological implications of that for that kind of cohort are. But what we're trying to understand now is, in the medium to long term, what do we need to put in place that kind of stabilises that and makes that more routine, and learn from what's happened already. So trying to up the ante in terms of what psychological support is available for our kind of service users. And that comes, and some of that learning comes from some put in place over the pandemic too. So not only the 24/7 crisis helpline that Rob mentioned, but we've also launched a grief and loss helpline to help members of the community who are suffering any form of grief and loss that's been generated as a result of being in the situation we're in at the minute, whereby they had the opportunity to really talk that through with somebody and not only be listened to, but hopefully signposted onto other services in their individual place. So it's a West Yorkshire and Harrogate service that interfaces with individual places. And then building on the bit that Ian mentioned about understanding what the demand is going to be for lots of our communities. For mental health in particular, it's by no means a neat science. And nationally, there's no kind of obvious kind of modelling that you can do to predict what the demand is going to look like. But lots of our public health teams in individual places are doing that now. And from a West Yorkshire point of view, we're benefiting from being able to suck that up and try to understand what that means in terms of what we might need to do at scale or to replicate services across individual places. And again, particular focuses there on what our vulnerable groups already are, such as our BAME communities, or indeed the impact it's going to have on children and young people. A couple of the specific points were around suicide prevention and where we're up to with the suicide prevention strategy. So it's kind of worth emphasising, I suppose, in a time like this, we're kind of quite grateful to the fact that we already had a team working on this and kind of a clear strategy for taking forward suicide prevention. So things like our suicide prevention trailblazers, which already existed across the patch, just continuing to take forward the work they were doing previously. We had our West Yorkshire and Harrogate postvention service run by Leeds Mine, which again is continuing to be funded to support people who are at risk of suicide as a result of losing family members or loved ones themselves. And we are fortunate that just before the start of the financial year, we were confirmed by NHS England to have what they call kind of wave funding for suicide, which is basically additional targeted funding to help suicide prevention. And we are using that in kind of two main ways, really. So one is to support that kind of West Yorkshire and Harrogate at scale support, whether that be things like real-time surveillance or how we provide comprehensive training packages, but also being able to help local places through kind of grant-based schemes fund interventions that are most specific to those communities as well. So that kind of process we've already gone through of allocating what money will kind of feed through to local places so that they can start deploying some of that in across West Yorkshire. And then finally, really, kind of there are a couple of other bits about how we are helping people back to kind of work and schools who have mental health problems. And it's worth saying that, again, there's already schemes up and running across West Yorkshire in a number of our places that support both elements of that. So we have something called individual placement and support schemes in areas such as Bradford, Leeds and Calderdale, which are there designed to get people with severe mental illness back into employment. There's going to be a renewed emphasis, I imagine, nationally and regionally on how we kind of pick up the pace on some of those over the next few months in areas which don't have them already, and a requirement for us to meet the kind of the expectations that are already there. And from a school point of view, we were lucky again, just before or just in the midst of lockdown, really, that we were awarded some further funding for something called mental health support teams in schools. So we already had a couple across places across West Yorkshire, which are basically teams that work alongside schools to help individuals who are struggling with their mental health, but we're able to broaden that out to other areas such as Calderdale and Kirklees that didn't have them before and bolster some of the support that we had in Bradford. And the final thing to say, because Rob's already mentioned briefly the Keeping Connected project about people with learning disability and autism and how we're stitching some of the support for them together. A lot of the learning too about how we kind of tackle some of the challenges we know present. So for example, we already knew that autism and diagnosis for autism is a challenge nationally, but across our patch in terms of waiting times for diagnosis. But trying to understand and learn about what is possible through virtual technology and what isn't, and what we kind of are already know to some extent is that it's easier generally to do diagnosis for people with autism when they're adults. It's much more difficult when they're a child or a young person, but actually how much of that learning can we take for children in the upper age of that spectrum? Actually, they're the 16, 17, 18-year-olds. Can we do more diagnosis virtually than we thought we could before? The honest answer is we don't quite know yet, but there's a lot of work going on to understand the kind of the impact of doing those sorts of diagnoses on individuals virtually, their experience and what it means in terms of their services going forward. So a range of stuff there, hopefully, which answers a few of the questions that were posed.
I just add a couple of bits of colour to that. So I think Kia's outlined a huge amount of work that's going on. I think it's probably worth the committee recognising that we think there'll be an increased demand in mental health services coming our way, and we can already see it. As a trust chief exec of a mental health provider, we can see that now, and that's because there's been some suppressed demand, and it's also because people are affected by the pandemic because they've either been ill or they've had some kind of loss. What we also know, though, is that we're likely to have significant economic impact. You've seen the job losses that are happening around the place. And in recessions, what you definitely get, we did a piece with the national team around what do we know from pandemics and their impact on people's mental health, and actually it's very little. But what we do know is that recessions lead to more suicides. And that's why the suicide prevention work that Councillor Smage asked about is so important, because the prevention work that Kia's identified will need to be stepped up to the level where we intervene sooner. One of the important things that I just wanted to mention on that was there is no evidence at this point that there's been an increase in suicides during the pandemic. You might see some things on social media about that, but there isn't any evidence yet. But partly that's because of the delay in reporting through the coroner. So what we're implementing is some fast track real-time surveillance on suicides, which will help us to understand what's going on and intervene. So I just wanted to mention that. So those things are really important. We will see an increase in demand. We're planning for that for the rest of the year, and we'll respond. And we do know that recessions also impact upon people's mental health and potentially increase suicide rates if you don't intervene.
Thank you for that. I mean, an incredible amount of work and information there from Kia. And thank you, Rob, because that kind of insight is really valuable. So thank you. And before we go on to the cancer question, Councillor Smage, is there anything you wanted to come back on that particular, on autism and learning
No,
suicide?
thanks. That was a very full answer. Thank you. I'd seen about your grief and loss service, and I thought that was a very good service to have put in place. So yes, that was a full answer for that. Thank you.
It certainly was, and as Rob says, we don't actually know the full impact yet because we're still going through it. But in terms of grief and loss, not being able to mourn properly is, even if you've lost a relative, which I lost my 6-year-old niece to cancer, which we're going to go on to, but to cancer on the 14th of April, and obviously that would be terrible anyway, but the effect on families and communities of not being able to mourn and not being able to grieve in the normal way, and I think that will have a knock-on effect in terms of mental health, people wanting to access mental health services going forward. So shall we go on to the cancer question then? And this is something that I'm particularly interested as well about, people not accessing cancer services during the pandemic as well. So I don't know who wants to answer Councillor Smage's question on that.
I'll pick it up, yeah.
Yeah, thank you, Chair. Yeah, I'll pick that up and try and answer those questions. And I do apologise in advance. I'm getting messages to say that my internet connection's unstable. So I do hope we get through this and I'm able to answer your questions. So yeah, as you'll be aware, cancer services have been significantly affected by the pandemic. Cancer is a progressive disease. In normal times, we'd be coming to this committee to talk about how we're trying to be more proactive about looking for patients and speed up treatments. We wouldn't be talking about how we're trying to cope with increased delays for treatment. So it has been a particular issue for concern. I think the positive is that all our system partners have been really committed to treating restoration of cancer services as a priority, and we've seen that as soon as we were able to start opening up some services as we've passed the peak of the pandemic, that cancer has been prioritised, and we've been able to move through some of the backlog of patients whose treatment was paused at the height of the pandemic. Clinical prioritisations guiding everything we're doing at the moment. All patients who are on pathways have been assessed against national
prioritisation criteria to look at how quickly they need treating if we're going to mitigate the risk of any clinical harm coming to pass. And I'm pleased to say that throughout the peak of the pandemic, our providers were able to continue to provide those urgent and essential treatments for patients, which is really positive. As you note, that there has been a concern about people coming forward and presenting with symptoms. At the start of the pandemic, we saw the urgent 2-week wait referral rates fall to around 30% of their normal levels, which was obviously a matter of considerable concern. They have been rising steadily since that peak in April, and actually in West Yorkshire and Harrogate, they're now almost back at pre-pandemic levels, which is really good. And we're running ahead of the rest of the country. So the rest of the country is now up to about 70%. We are closer to being back to normal. So that is positive, but obviously there will be a legacy of people who haven't been presenting when they normally would have done. And we're doing work now to understand where those patients are and what tumour sites we might be particularly have been missing cancers in, or people haven't been presenting at the same rates. So for the patients who were on pathways at the time the pandemic started to peak, most pathways were paused while the patients were clinically reassessed, and with their clinicians will have decided whether it was safe to continue with treatment, whether to modify the treatment plan, or whether pausing until things were a bit easier was the way to go. So some patients have been waiting longer, but all treatment modalities have continued throughout for those patients who absolutely needed it, whether it was a case of life or limb or so on. We've been working with the 6 hospital trusts in West Yorkshire and Harrogate as services started to reopen, to look at how we could restart safely and how to maximise the capacity that was available to treat patients quickly. Especially now we're in the restoration and recovery phase, and we're working, as Ian said, with the Planned Care Alliance partners to make sure we move forward around diagnostic and treatment in a sensible and planned way to ensure that clinical priority continues to drive what we do and where we open up services. Every organisation in West Yorkshire and Harrogate in our acute partners has been opening up services for cancer in either COVID protected sites, such as the work that Mid Yorkshire have done to designate Pontefract as a site for treating cancer. Within Leeds Teaching Hospitals, Bexley Wing has obviously been an obvious place for ring fencing cancer treatments, but all our partners have got COVID-free zones or areas where they are treating cancer patients. You may have heard quite a lot in the media about the development of cancer hubs. This was led by immediate response to the pandemic in London and to a similar extent in Manchester. Where there was an encouragement to look at focusing cancer work in particular hospitals. In West Yorkshire and Harrogate, we worked with our acute providers to see whether that was an appropriate response for us. Unlike those areas that led the way with cancer hubs, there isn't a particular designated cancer hospital like the Royal Marsden or the Christie. And in West Yorkshire and Harrogate, we felt that wasn't necessarily the way to go. We have been working across West Yorkshire and Harrogate providing mutual aid. So to some extent, Bradford and Airedale have been working together to look at how they can maximise the capacity available. And similarly, Leeds have been working with Harrogate and Mid Yorkshire to look at how they can open up capacity. But for the time being, at least at the moment, we're not looking at significantly changing patient pathways, because we have managed to treat our urgent time critical patients within their usual hospitals by and large, without the need to move patients about. Having said that, we have developed a policy, and we have a policy on standby so that we could run a West Yorkshire and Harrogate waiting list to deal with overflow of patients if people can't be treated in a timely manner in their local hospital. We haven't had to deploy that yet, And other than in London and to some extent in Manchester, I don't think any other cancer alliances have needed to either. So we're not alone in that respect. I think the other question Councillor Smage you raised was about communication strategies. We have managed to maintain our patient engagement work, I'm pleased to say, throughout the pandemic. A lot of it had to move on to digital platforms, which I know excludes some people, and we've been particularly conscious about that. But we have managed to, in fact, to some extent, we've actually increased the working we were doing with our community patient panel, who have been really engaged using Zoom and telephone meetings to help us deal with some of the problems we've got. So as we were starting to reopen services, we've done a lot of work with those groups about what it would take to make cancer patients feel able and safe to come back into NHS services, because we know at the outset of reopening services, a number of cancer patients, particularly those who've been shielding, were reluctant to come forward and come into hospitals because they perceive them to be not safe places to be. So we've done a lot of work with our patient panel about those issues and shared the outputs from that with our providers and with our Alliance board. Going forward, as I say, we are doing work with the Yorkshire Cancer Community, which is a charity that's got a reach of about 10,000 people affected by cancer across Yorkshire and the Humber. We had been already starting a partnership with them around developing a variant of a cancer champions approach. As the pandemic's progressed, we've got more into discussions with them about how we can use the relationships that we have and they have through their community networks to reach patients. So as we do the work around trying to identify where we might have lost, for want of a better word, cancer patients coming forward, we're planning work with them that will use some digital, but some community networks and other verbal and more face-to-face as we're able to contacts to encourage people to present where we think we might particularly have been having populations that haven't presented, whether that be a geographical, whether it's based on deprivation, whether particular tumour types haven't presented, or particularly our BAME communities. So we've got that all in our sites, and that's beginning to ramp up again now. So thank you, I hope that's been helpful.
Yes, thank you. And I'll leave it there because there's other people who want to ask questions. Thank you.
Thank you.
Incredibly comprehensive. Thank you very much. There's such a lot going on that, because you get a bit scared from what you hear in the media. So that was really quite reassuring. Councillor Greenwood, can I bring you in, please?
Thank you. Yeah, mine's going back to mental health. We've had a lot of information given to us there, really interesting, informative stuff. So thank you for that. I know there is a lot of work going on at the moment for people that are known to the service, but the people that worry me most are those that are not known to the service, possibly those that have got mild anxiety. They've never really sought help for it, but now obviously this pandemic's made it a lot worse. I think it was Rob that mentioned a crisis helpline across West Yorkshire. I've missed that, might be just me, I don't know, I wasn't aware of that. So if I'm not aware of it, maybe a lot of those people that are looking for services, it might be helpful if we can get that out to the wider public, really, so that they do know where to go. Other than that's all I have to say, because everything else has been answered, so thank you for that.
I don't know, Keir, if you want to give any of the numbers for the sort of crisis helpline and what sort of volume of people coming forward.
Yeah,
if you want to email them to us, and then we can to Carol, and then she can, if that's all right, Carol, and then she can distribute them to everyone, because yeah, I know that we're kind of developing one in Leeds, but I wasn't aware of a West Yorkshire one. Sorry, yeah.
I think that it's a West Yorkshire service, but it's locally targeted. So each of the places has got their own response saying this is a crisis line that you can ring for Leeds, or you don't have to be already known to services. I didn't know if Keir just wanted to give some numbers in terms of the volumes of people who are ringing up, just give you an idea of the kind of scale.
Yeah, so it's increasing month on month. So it's been live since May fully. And predominantly the numbers of people phoning in have been generally around kind of low mood, like you say, Councillor Greenwood, kind of a generalised anxiety. And what they have often been helped with is kind of signposting to support that they can help with that kind of element of their kind of needs, where compared to actually relatively lower numbers of people, thankfully, who are in kind of, full-blown crisis, who need referral onto kind of secondary services. But the numbers were kind of in the 300s, 400 in kind of month one, then kind of 500 or so month two. So it's going up gradually as we kind of move forward. So what we'll be able to do, like Councillor Hayden says, is kind of share the latest data on that, and actually kind of what's happening as a result of those contacts and where they're coming from in terms of location and ethnicity as well, which is quite interesting to see.
Excellent, thank you. Yeah, and if you share with us the actual number, and then we can get that out to our residents, constituents, yeah, that'd be lovely. Thank you. Shall I bring in Councillor Hutchinson then, and then Councillor Clark?
Thank you, Chair. There were actually 3 areas that I was wanting to ask questions around. One is around the test and trace process. The other is the demands that have been made from the Chief Executive of NHS England last week for the 3rd phase of the NHS response to COVID-19. And the 3rd area was the use that we're making of the additional facilities that have been made available during the response. So as far as the test and trace process, I'd like to ask a fairly may seem a daft question to start off with, but £10 billion or thereabouts has been allocated to the test and trace service, so it's obviously felt to be important. But how does it stop the spread of infection?
So I think if I'll start with that, and then Anthony and Sarah Muckle might want to say something about that. So I think it's probably just worth giving a bit of background in terms of the response locally first, because I think it's important to understand that. As we've been through the last few months, it's been clear that the amount of capacity that was available in the NHS labs to do tests was really low, and there wasn't a national testing system. So what's been set up from scratch is, a testing system nationally with further enhancements to local NHS labs, which have massively increased their capacity. And as an integrated care system, as a partnership, what we've been trying to do from the start is say, okay, so if they've got these things going on nationally and locally, how does all that come together? And Anthony Keeley, who's on the call today, and as Ian said earlier, Martin Barclay have been coordinating that work to make sure that our test and trace approach took the best of the national stuff and the best of the local stuff and made it work for West Yorkshire, but also in the places. And then people like Sarah have been on the end of how you deploy it during an outbreak. So in that context, Sarah, do you just want to describe how it works and why it quashes outbreaks and stops the spread?
Yeah, absolutely. So we do know that some people have this virus and don't have any symptoms, and we also know that people are infectious up to 48 hours before they get symptoms as well. We do contact tracing already for a lot of things before this pandemic happened, and people will be very familiar with it. So things like for meningitis, for example, for TB, what we want to do is identify people as early as possible who have this virus and make sure they get the right advice. So for people who test positive, we want to know who they've come into contact with. By doing that, we can assess whether they need to be tested and give them advice about self-isolation. So it's absolutely crucial in stopping the spread of this virus and lots of other things as well. So we need to make sure that anybody who has come into contact, who has potentially come into contact with this virus, is given the advice as quickly as possible to self-isolate, and that's usually for 14 days if they don't have any symptoms, and by then they will have developed symptoms within that isolation period if they're going to. So it's absolutely vital, and we do realise that there have been some issues with the national system. So you will have heard a lot in the news from Blackburn and Darwin, for example, that a lot of people are not engaging with the national system, and that's why many of us are looking at local options in terms of how we add to that national system and pick up locally people who are not necessarily engaging for whatever reason with the process we've got with Public Health England and the national team.
Yeah, but the point I wanted to emphasise is that doing a test doesn't stop the virus from spreading. What stops the virus from spreading is people isolating who either have the virus or may be incubating it. Do we know how effective our isolation procedures are proving? And can you think of any barriers that there might be? You know, is it sufficient for somebody to give their word as an officer and a gentleman that they're going to self-isolate for up to 2 weeks? Do you think that people who have a high rate of self-employment, informal or precarious jobs, or no recourse to public funds are likely to comply with that? And are there ways in which we could actually ensure that they comply? Because there seems to have been an awful lot of resources put into the test and trace system, but precious little into actually making sure that isolation takes place effectively. Without that, the rest is a waste of money.
You're absolutely right, Councillor Hutchinson. The isolation is absolutely vital. However, we still need to be identifying people who are positive, who are not positive. It's much easier to persuade people to continue to isolate if they know there's a really clear reason to do so. So I suspect that when we've got people with no symptoms who feel perfectly well and don't have any real belief that they might have the virus, it's much more difficult to persuade people to take 2 weeks out of their life and to isolate when they've got probably a lot better things to do. It's difficult to police, and I take your point. I think there are different groups of people that find it much more difficult to self-isolate. People are low-paid workers, insecure employment, people who are self-employed, absolutely. We have to get the messages right on this, because it's much more, has a bigger impact on businesses if people then spread that virus around workplaces. We have had conversations, I know nationally there's been conversations about whether we can financially support people who need to self-isolate, and I know those conversations are happening at the minute, but it is a continuous challenge, and the biggest and most overwhelming thing about this is that we have to get every part of our cities and our districts playing their part in order to really contain this virus as quickly as we can. And people don't find it easy to isolate from the life that they've got. They don't find it easy to stay away from different family and friends. But if we can do that, the quicker we can do that, and the easier we do in terms of getting the messages right, the more likely we've got of getting this under control.
So I think within that, Sarah, I would really emphasise the point about communication. You talked about, you know, simple, clear communication, and Councillor Hutchinson's right. I mean, I always tell people the virus hasn't changed. You know, it's still as infectious as it was before. It's what's changed is the pattern of how we live our lives and how much we come into contact with each other.
And I would suggest that having the ability to reinforce that during the period that somebody is in self-isolation, rather than a single phone call, anonymous phone call from a call centre telling them to isolate and then nothing, that it's the sort of thing that does need to be followed up through that period. The numbers actually are not that great. And I would like to ask the committee whether we can actually make representation to the Secretary of State to request financial support for those where finance is a barrier to them actually complying with isolation. So I'd make that request to the committee.
I think that's an excellent idea. I mean, if people are having to choose, and I know people, particularly in the private sector, who with sick pay isn't that great if you're on a low paid job anyway. Well, it's worse. It's terrible that they're having to choose between going to work and earning money and surviving that way, and protecting themselves and their loved ones and the general community. It's a really hard decision to make, incredibly hard decision to make, and it's how we police that. Yes, I'm happy if the board is happy to make representations on this issue about because we can get test and trace right, but then as you're right, if we don't monitor or support people in isolating, then so can I get agreement from the board to do this? Yeah, is that a yes? Yeah, lovely. Thank you. So if that's okay with Mike, then we can put something together and share it with the board after this meeting. Thank you very much. Councillor Hutchinson, your other questions.
Can I move on to the demands that the Chief Executive of NHS England made last week in the third phase of the NHS response to COVID-19? In particular, first and follow-up outpatient appointments up to 90% of the numbers that were being seen last August and 100% in September, that elective and day case surgery should be back up to 90% by October, and MRI and CT and endoscopy to 100% by October. How realistic is it that we will be able to deliver that across West Yorkshire? I'd also particularly like to ask about pain services. Having people living with persistent pain that is very difficult to treat is not humane in the slightest, and that should be one of the priorities for our health service to restore. But I know within Calderdale and Kirklees, the pain services were discontinued during the most intense part of the pandemic, and there is no date yet for them to be resumed. I'd also like to know about cancer screening services, because the breast screening program was halted in the immediate stages of the pandemic. When is this likely to be restored, and other cancer screening services? So I would also like to make a comment that some places have considered shared waiting lists for elective surgical cases. And I would very, very much hope that we don't go down that road in West Yorkshire, because the decision to carry out elective surgery does depend on a full discussion with patients about the balance of risks and benefits and exactly what's going to be done with the patient. I've been myself involved in taking on shared waiting lists, and when you have a surgeon being asked to operate on somebody where they don't actually agree with the original decision or some of the aspects of that decision, it becomes an absolute nightmare, both for the patients and for the surgeon who's being asked to operate on them. So I really hope that we don't go down the way of shared waiting lists in tackling these problems. So.
Jack, perhaps I can make a start on this one. I'm Anthony Keeley. I'm the NHS England Locality Director for West Yorkshire and Harrogate. So Councillor Hutchinson talked about the expectations that were set out in the NHS Phase 3 letter last week around increasing levels of activity much closer to normal levels, and you asked how realistic that will be. I suppose the first thing I'd say is it will be challenging. There are all sorts of constraints on being able to get back to something like what we used to recognise as normal, and we've talked about a number of those in the meeting today. Things like that the need for social distancing within hospitals obviously creates restrictions on numbers of patients that can be treated. Levels of personal protective equipment or another constraint, that we need to make sure that we're operating safely within the levels of kit available. And I guess public confidence as well is a real issue. We've talked about that. Making sure that people feel confident to come in to safe, COVID-safe environments to have the treatment they need. So it will be challenging. We'll be working with our partners in trusts and CCGs over the next few weeks to work up our plans to see how close we can get to those expectations. One of the benefits of us working as a partnership across West Yorkshire and Harrogate is to see how we can sort of team and ladle, if you like, the capacity we need to have between hospitals. Different hospitals have different levels of physical and other constraints that we'll have to manage flexibly and be agile to work our way through that over the coming weeks. So I'm sure we'll get there or thereabouts, but it is going to be hugely challenging. I think we'll be really supported by the opportunity to continue to access private sector capacity. You may be aware there's been a national contract to make private sector hospital capacity available to the NHS since April. That will continue for the rest of the year through a modified national contract arrangement. And of course, we'll also be able to think about how we can use other facilities like the Nightingale, which won't be suitable for a wide range of inpatient activity, but obviously will be of benefit if we do have a further spike of COVID itself to help keep other capacity available for other types of treatment. Councillor Hutchinson asked about screening, and one of the expectations again from the letter on Friday is that we get all screening programmes back up to normal pretty quickly, and that process is happening now. So hopefully, I think Carol Ferguson talked a bit about this in the context of cancer earlier as well. So we'll be working to make sure that screening is back up and running, as well as wider sort of vaccines programmes as well. And on the question of shared waiting lists, I think very much recognise the sort of concern the councillor raised around, if you like, centralising all of this and expecting everyone to sort of operate through a pooled arrangement. And that's not what we'll be doing in West Yorkshire and Harrogate. We'll be working in a way which focuses on individual places, individual hospitals continuing to manage their own demand for care. But if you like, on top of that, making sure that we are not introducing new levels of inequality. So we absolutely can't have people waiting for 2 weeks in Leeds and 20, 30, 50 weeks in Wakefield. So we will be looking at how we can support patients where it's suitable and appropriate for them to do so, to be treated elsewhere if they want to do that, to enable them to have shorter treatments. And that's part of that way of equalising our capacity across the system, but very much based on that principle of the importance of local services. So hopefully that's some help in terms of the work we're
if I could just add
in those areas.
Yeah, it's really helpful, Anthony. I think, and we are, as a system, the acute trusts are ambitious to get activity back as quickly as we can, as safely as we can. We're all really cognizant of the clinical risk that is building, and really keen to address that. One of the things that we have done over the last couple of weeks is we've been doing a piece of work bringing the system together to look at how we can think about surgical capacity and surgical productivity differently. And so there was two events I think Anthony was part of last week to try and do that and to try and map through what sort of different arrangements that would look like, so that we're using the capacity that we've got to its to its best effect, really. So yeah, a lot of work over the next month or so. It will be challenging, but we are ambitious.
Could I
just a final thing to mention in that is that I think Councillor Hutchinson raises the issues around things like outpatients, and what we've seen is that for many people, a physical attendance isn't required for an outpatient appointment. It's something we've been reaching for a long time. And what we mustn't do in trying to deliver the targets around getting back up to a reasonable level will be to reintroduce all ways of working which are based on the 19th century model of outpatient attendances, for example. So we'll continue to try and make sure that all of the improvements we've made around digital continue. And we must always have this mindset, I think. We're not going back to what it was like before. We're going towards something new, sometimes which will be better, but sometimes will require choices which might not feel better. And we have to be honest about that.
Yeah. Thank you. Do you want to come back very quickly? I'm just aware of time, and that we want to discuss the update on the BAME Commission review.
It's just the pain services side of
oh
things.
yes, yeah.
If pain services aren't addressed, there's going to be pressure within primary care for people to be given potentially addictive drugs in attempts to control their pain, and opening up all sorts of long-term problems from that point of view. And I just wondered if there was any overarching plan proposals for the pain services across West Yorkshire and Harrogate.
I think, can I make a sort of general point before I bring in the others? I know Councillor Smage has asked about safe discharge. I think, as often is the case, we've spent a bit of time here on what's happening in hospitals, but you'll recognise from Ian's piece earlier that the priorities are around community as much as about hospitals, and how we're joining up services around populations to make sure they're getting good joined up care that meets all their mental, physical and social needs. And the letter that we got last Friday night does talk about, you know, investing in community services and making sure that they're joined up, and we continue to operate around communities and care homes. And what I would hope is that things like pain management, psychological support, all the gains we've made through our primary care networks and wider partners are in place to make sure that people feel a bit more supported and held by a team in their community. And that builds on work that we've done with care homes around discharge, for example, where we have a named clinician for every care home. We have a multidisciplinary team for every care home, and we have support wrapped around all of the care homes to make sure that people are receiving the treatment that they need. But as a committee and as leaders, I think what we have to do is keep focusing on what's going on in people's homes and in their lives and in their communities as much as what goes on in hospitals if we're going to be successful. In terms of the pain services specifically, they need to be part of that. I don't know if Anthony or others want to mention anything specific on that. If we've got time.
Well, just to agree with that, Rob. You know, we don't have if you like, a single model of pain services across West Yorkshire and Harrogate. These are very much organised in terms of the pattern of local services in each place. I fully agree with the council that these are critical services and will increasingly be so to support people who are not least recovering from COVID, as well as the other range of services that require that support. So we will absolutely be looking at how those are reintroduced and made accessible through the kind of local community service models that Rob talked about. And if I can just add to the point about safe discharge, which I know Councillor Smage asked earlier as well, I guess this links back to the testing issue we were talking about earlier. You know, Rob and Sarah talked about the significant increase in testing capacity that we've had over recent weeks, and of course, you know, patients being discharged from hospital will now have a test before they are discharged. And there's a whole range of work going on around making sure that discharge is done in a safe and timely way. Not least, the government has now committed, again in last Friday's letter, to funding timely discharge for the rest of this year, in that patients will have 6 weeks of funded care following discharge, without having to argue whether that's an NHS or a social care responsibility. So that will allow patients to be discharged to the most appropriate place when they're medically fit to be discharged and tested for COVID. And we can then discuss, you know, while the patient has been discharged either to home or to another appropriate place, what the ongoing responsibility is for funding their future care. So I think that'll be a real advantage as we go through the winter in terms of making sure that hospitals don't have patients in beds who don't need to be there.
That sounds a positive step forward there.
I think it really is, yeah.
Yeah. Instead of that mess about who's got funding what and, you know, and where people are going, that results in people staying in hospital. Councillor Clark, can I bring you in? And welcome, and you weren't here to introduce yourself, but and thank you for waiting. You've waited quite a long time there. So would you like to ask your question, please? I think you need to unmute yourself. Oh no, it looks like. Oh, I can't hear you. Would you like to, can anybody else hear Councillor Clark, or is it? No, no. Right, it might be something on your computer, Councillor Clark. I don't know whether you need to turn the volume up or something. Oh. Do you want to try now?
We can see Councillor Clark now, but can't hear him.
Yeah, I can, and his box did go yellow, but then, okay. Can any technical support maybe get in contact with Councillor Clark and we can move on. Thank you, Councillor Baines, for your comment there in the on the using new technology. It's really good to have this chat actually. And Ian, you're going to feed Councillor Hutchinson's point on paying to the Planned Care Alliance Board. Thank you very much. That's great. Carol, did you want to come in?
I just wonder, it might be easier if Councillor Clark could type his question and then his question gets through.
Yeah, if you'd like to type it into the chat, Councillor Clark, and then we can answer the question there. Okay, I'm talking. Okay. Right, well, we'll move on. And if Councillor Clark, if you can put your question into the chat. If you can't, if you want to email a question, and then I'm sure partners will answer later on. If you can't get through, if you can't get through later on, shall we move on to that was really involved and really interesting and an awful lot of information. We want to thank everybody for those detailed answers and a wide range of issues. So one of the things that Ian mentioned that were already there, thank you Andy and thank you Kia, they're having to leave now. One of the issues that Ian mentioned in his presentation at the beginning was the fact that one of the ambitions about from the 5-year plan was that poor experiences for Black, Asian and minority ethnic staff were a thing of the past, and obviously that's been highlighted in a very dramatic and quite tragic way through the COVID-19 pandemic. That I think the first 4 doctors to die were from Asian heritage, and those, so this commission review, so really important and fits in with what we were wanting to already do. So I'll invite Fatima Shah and Sarah Smith, please, to talk on this report, and then we can, as we've done before, to pose any questions. So I don't know who wants to go first.
Thank you, Chair.
Sarah's going to start, aren't you, Sarah?
Yeah, I'm going to kick off and then I'll hand over to Fatima. I'm just going to give a bit of background and then Fatima's going to give some information on the BAME network and the review in a bit more detail. So just to give a bit of a background in terms of where the reviews come from and some work related to health inequalities to date, just really quickly. As you've described, really, we had a focus on reducing inequalities for BAME staff and also populations as well across West Yorkshire and Harrogate from our system working. And what our learning that we've taken from COVID is kind of really emphasised that and wanted us to kind of really make some progress and drive that forward, both in terms of the impact on staff themselves and then the direct impacts on the community, so people actually becoming unwell and dying from COVID and the links there with specific Black, Asian and minority ethnic groups. But also the indirect impact. So we're getting the insight we're getting in from local communities, working with the voluntary community sector on the indirect impacts of lockdown and COVID and that's having on our different communities. So for example, job security, housing circumstances, and then real sort of fear and anxiety of accessing health and care settings and all of the impacts that the knock-on impacts that those things can have on BAME communities as well. So what we acknowledge in all of this, we wanted to kind of do a piece of work as a partnership and decided to conduct an independent review, looking at what work we've already done, but really kind of testing that and bringing someone independent in to test that as well. And to help us prioritise some deep dive areas that we're working through at the moment, which Fatima will come on to, where we can really look in a bit more detail about what's happening now, but also what we could do better in the coming months and years as well. So in terms of progress to date, we've got a couple of kind of key areas that goes to at the partnership level. We've got a health inequalities network, and one of the key focuses for that network, amongst other areas, is the impact on health inequalities for our BAME communities. Some of the work we've done to date is really bringing together that insight I discussed and sharing good practice between places in terms of focusing on vulnerable groups. But also the health inequalities grant funding we touched on earlier. Some of the funding we've allocated for there, so 7 out of the 13 grants we funded have a real focus on BAME communities. So some really specifically around kind of South Asian women and diabetes prevention, some broader pieces around BAME groups in general and mental health in places, and then some real specific minority ethnic population groups. So we've funded a piece of work for refugees and asylum seekers in Kirklees, and also funded a piece of work for supporting a gypsy and traveller populations across Bradford and Wakefield. So that's just a bit of a flavour of some of the things we've been able to fund kind of during the COVID period. And then what we wanted to do, like I say, is kind of test it during the review. So I'm going to hand over to Fatima now, who's going to kind of give a bit of an overview of the work that's happened to date across the BAME network and staff and the key aims and where we are with the review process itself.
Thanks, Sarah. Good morning, everyone. My name's Fatima Shah. I'm a Programme Director within the partnership leading on personalised care and the unpaid carers programmes. I'm here today in the capacity as the convener of the BAME network, which I'm not sure whether you've heard of, but it's basically a network of networks consisting of chairs of local authority as well as NHS organisations and BCS colleagues, as well as leaders from across the system who are either from a BAME background or are passionately supported to committing and supporting the agenda. So it's a very, very proactive network. I think what's really important to recognise is the fact that the network was created prior to COVID hitting. So the ambition of West Yorkshire and Harrogate, I'm sure you're aware, is that we wanted to make sure that the leadership was more reflective of our communities. And there were many reasons behind that, but one of the most important ones, which I think COVID has brought to the forefront, is that diversity and representation in our decision making as well as our scrutiny of decision making is crucial. Because if you don't have the thoughts in the room, if you don't have the representation of lived experience in the room, we may inadvertently perpetuate inequality. And that's really, really important that we think about that in all the things that we're doing. And some of the stuff that I'll be talking you through will be about the action that we've done to address that. I think there's also something about recognising that in order to achieve the ambition, it's important to amplify and understand the lived experience of the people impacted by that ambition. So one of the things that we did very early on in January this year, although it feels like a lifetime ago, was to co-produce how we're going to fulfil that system ambitions. If we are going to make our leadership reflective of our communities, and we need to recognise that the data is saying that's roughly 20% of our leadership, So we need to understand what the issues are, what the barriers are, and how we can work together to address them and remove them, which is what the aim is in general. There's also something about understanding the contribution and talent within the system. So this is very much a positive conversation, recognizing that actually no one is setting out to create these barriers, but they exist. And we need to work together to address them and remove them, but also support our talent to get into those leadership roles. And that will require some resource, that will require some work and some time. And we were very much in the process of evolving what that would look like prior to COVID hitting. Then COVID hit, and obviously, like you've alluded to, Councillor Hayden, it was very, very easy to see early on that there was a disproportionate impact on our communities. And as an Asian woman myself, when I was seeing that on the news, and when I was hearing the statistics from the Office of National Statistics, which says that if you're a Pakistani person, you're twice as likely to die from this. My husband's a pharmacist, he's out there every day coming into contact with his patients. If you're someone from a Black Afro-Caribbean heritage, you're 4 times more likely to die. That's my colleagues, that's my friends. It's scary. And our network members very early on were getting feedback from community representatives who were receiving fake news, unfortunately, but also frontline staff who were really, really worried and had questions that they needed support on, that we felt we needed to take action really quickly. And thankfully, due to the leadership of Rob and Ian and other colleagues from the system, we were able to respond quite swiftly and pivot our response to the areas of most need. They initially were, supporting research. So why are we seeing the numbers we're seeing? Why is it, impacting certain parts of the community and not others? Because all BAME people are not experiencing inequality in the same way, and all BAME people are not the same. We're not one homogenous group. We have different heritage, different life experiences, and the socioeconomic argument differs depending on where you live. So, I'm fortunate enough to have a really good job. I live in a nice part of Kirklees, as Councillor Smage knows, and it's just that thing of, we can't tar everybody with the same brush. We need to ensure that whatever we're doing doesn't perpetuate the inequality, but also hits it where it's most prevalent. There was something about doing that and then countering the fake narrative. So some of you may have heard, if you're on Twitter, about a podcast that we've developed called Can You Hear Me? And the first one really focused on understanding some of the questions that people wanted answers to, but were too scared to ask. They were too scared to ask because they were scared of being sacked. They were scared to ask because they weren't sure who to ask it to. And we had a really brilliant panel, if I may say so, of experts from health and care. We had somebody that was quite a leader in Leeds in social care, as well as some NHS leaders, talking about the impact of COVID and also addressing some of the questions about how we stay safe, either in the workplace or out in the community. There's also something about tailored communication. So, you may have seen something in the press about people not understanding the guidelines. Having information in the different languages isn't enough in the written form. I'm someone who can speak 6 languages, I can read only 2. There's something about ensuring that we have bespoke resources that are in different formats to ensure that we reach the communities, but also that they're heard from people of influence that people will listen to and trust, because trust is a big issue at the moment. And then there's something about realising the emotional load and impact facing our community. So someone who is experiencing this right now, has recently had a bereavement, is away from their extended family, is worried about my loved ones. There is that emotional load that we need to manage every single day. And the network has been instrumental in creating some bespoke resources to really meet the needs of those different communities, both from a cultural as well as faith perspective, because we know for some of those communities, the faith element is very, very important. I think the final bit that I wanted to flag as well was, some of you may have heard about the emphasis on risk assessments, about making sure that our staff remain safe. And what we've done as a network is very much support that with some tangible resources, but also looking at it from both perspectives. So, our frontline managers have been put in a situation that they weren't expecting. They need support to enable to have those constructive but meaningful conversations. And it's important that both parties leave that conversation feeling comfortable and that they've achieved the objective of what that purpose was, which is that everyone stays safe, but we're able to continue to provide services. And the network has been really, really important in that. The final bit I wanted to flag sort of prior to sort of moving on to the review is, this is not about talking. So we've heard a lot about what the evidence is telling us. Many of you will have seen lots of different bits of information. The difference, I think, within the leadership of West Yorkshire and Harrogate is that we are acting swiftly, and we're trying to do whatever we can at a fast pace. One of the examples is obviously Rob's call to action that he's written with the NHS Confederation, but also backing that up with a letter to all the system leaders, chief executives of health and care organisations, asking to move on some of the elements of our system ambition. So going back to the ambition that we had in January about making our leadership more reflective of our communities. One of the key things within that was recruitment and selection, about the makeup of our recruitment and selection panels, as well as the representation of diversity within our decision-making forums. Both those letters have been well received. Many of your colleagues in the local authority have responded to us on that. And that's enabled us to have representation in some of the most influential decision-making forums of our partnership. So our System Leadership Executive Group has representation from the BAME Network, our People Board, our Health and Equalities Network, led by the fabulous Sarah, and the People Board, because in order to address this issue, we can't focus on one part of the system. This is like any other change transformation program. It will take time, it needs resource, and it needs investment as well. So then moving on to the ethos and values really of our partnership, which is very much that we don't want to just focus on patting ourselves on the back, aren't we wonderful to be doing all this activity. It's about understanding what more we can do, where the gaps are and where we can add more value, which is why the review was initiated. And the focus of the review was not just to understand the impact, but to review the work that we're doing so far, exploring whether it's sufficient to address what it is that we want to achieve, and also identifying recommendations for action. And I think one of the instrumental moments of the review actually was when Rob speaks, which, is instrumental, whenever Rob speaks, everyone listens because he's like that. But I think what was really important was, the fact that we felt it was really important to talk about race and racism. And I think sometimes when we talk about health inequalities and reviews, we acknowledge racism exists. We know that structural racism exists, but we kind of sidestep it. This was a real sort of step from the leadership to say, no, we want to look at this head on. We're not going to shy away from this. And we want to consider the bad as well as the good, which I think is really, really important. And to not shy away with the uncomfortable conversations. So my new mantra at the moment is very much get comfortable with being uncomfortable, because we need to have these uncomfortable conversations to address the inequality. And the final bit is about representation. So very much trying to hear from the voices that we don't normally hear. So I am a usual suspect. Yes, I'm a BAME leader, but I get into the forums of power and people hear what I have to say. What's really important is that we hear from those people in the grassroots of our partnership about the adverse end of this, and to hear from them what more we can do to address this inequality. So just to bring you to the recommendations and sort of what the areas of focus are for the review, they are 3, and there were many that we could have done. And I'm a woman that wants to try and save the world, and Ian Holmes is very much the man that says, no, Fatima, you need to focus only some stuff at a time. And the first one is very much about reducing inequalities sort of to access safe workplaces for our BAME communities. It's very much looking at the proportionality of occupation, as well as the proportionality of our staff, and really trying to understand what that means. And then there's other bits about trying to improve our understanding and focusing improvements on health outcomes, which we're in the process of finalising and will be subject to the review, agreeing to those outcomes in the second meeting, which is taking place on August the 6th at 9 till 11. So just to sort of make you aware that the papers are available in the public domain, I would really encourage you to look at the data pack from the first meeting. It's really insightful in regards to where we are as a system, in regards to our communities, as well as our staff, where we are so far, because I can't do it justice in about 10 minutes, but also where we think the areas of improvement are, and also some of the other discussions that we've had in the meeting. So just to finally close, because I'm mindful of the time, very much looking to the panel to consider the work underway and to know what we've just presented to you, but also to explore with you whether there are any other areas that we could look at, any specific recommendations that we may have missed. Before I do that, I just wanted to hand over to Rob and Ian in case I've missed anything.
Thank you. That was brilliant. Thank you. Rob, Ian, do you want to say anything?
No, that's comprehensive. Thanks.
Nothing else from me. Thanks. No, it was a really good update.
Yeah, it was fantastic. Thank you. I've got Councillor Smage with a hand up. I've got the hang of this now. It's great.
Thank you. I think it's a really good paper that you've produced. I've just got a few questions. I can remember at the start of the West Yorkshire Partnership, a discussion with Scrutiny about health inequalities being at the centre of everything. And I can remember asking about health inequalities being front and centre in your Memorandum of Understanding. And I think what has happened over the last few months has brought health inequalities to the fore more, and there are probably more health inequalities now than there were previously. And I think that it needs to be system-wide, the look at health inequalities in relation to services and how health inequalities across West Yorkshire can be helped by the health and care services going forward. I did look at your papers for your July meeting on this, and I noticed Kirklees, you were only talking about one part of Kirklees on your papers. So I just want some reassurance that you're talking about different communities across Kirklees as well as just one area. You talk about targeted work in your report, and I wondered if you'd got any targeted milestones. Thank you.
Not sure to take that, but I'll jump in first on the Kirklees question if I may, and then I think Rob.
I'll just say something about inequalities first.
Yes.
I think Councillor Smage is entirely right, and myself and Robin Tuddenham, who leads the inequalities work, have written for the Local Government Chronicle and the Health Service Journal on we risk increasing the gradient on inequalities unless we do something active at this point to reduce inequalities. And the 5-year plan that Ian referred to, the 10 big things in there, the very first one is about improvements in healthy life expectancy and changing the differences that exist in each of your places in our communities on that. And then some focused work on people with mental health and learning disabilities who face significant health inequality, some focused work on children in poverty. So we've already got that right up front in terms of what we want to achieve. And then through Robin's work programme and through Sarah, we've got a huge amount of work on what the practical differences we can make that will tackle inequality, whether that's the economic recovery and where that's focused and on which communities, or whether that's the work that we do as health and care partners. So very much welcome, Councillor Smage, your intervention there, and we will and must continue to focus on it. Owen Williams, one of the local chief executives, has been doing some work nationally, which is about to be published, which puts in place expectations of all NHS organisations to help with inequalities. So we will embrace that, I think. In terms of any of the specifics, Fatima and Sarah can give you some of the insights there.
So I was just going to add, obviously, as a Kirklees former leader, resident, very much recognised and cognizant of the diversity of Kirklees, very passionate about making sure that we recognise the diversity in different cohorts of our BAME communities. In regards to your specific ask about, the health inequalities lens and the work of the partnership, just adding to what Rob's just alluded to, from a programme perspective, we all have inequality objectives as our programme's governance. So we're very much making sure that it's cognizant in all the work that we do as well. So I just wanted to give you that reassurance. I'm sure Sarah can add something as well.
Yeah, just to add to it in terms of some of the specifics and the things we're working through. Obviously, there's a kind of system, sort of strategic ambitions that we've got set, but the work we're doing now through the Health Inequalities Network and supporting the work of other programmes as well is kind of really looking at what specific things we can do across pathways of care to reduce inequalities. So whether that's sort of inequalities in access or inequalities in preventive interventions such as vaccinations or screening, they're the kind of things that we're looking at. And through all of it, we're taking the lens of what makes sense to do at the system perspective from a scale point of view, and where it makes sense for things to happen locally in place, where can we share examples of good practice to reduce inequalities. And the different population cohorts we'll be looking at will depend on sort of what intervention we're thinking about. But overall, we will have a lens looking at our most deprived communities. We will have a lens looking at different Black, Asian and minority ethnic communities. And within that, it will depend on, again, which are most affected. We'll also be looking at, as Rob alluded to, people with mental health conditions, learning disability and autism, and how they might be disproportionately affected. But then in addition to that, we'll be looking at some other groups across West Yorkshire and Harrogate that are kind of really acutely affected by health inequalities. So rough sleepers, for example, and we're leading a specific piece of work looking at access to specialist mental health care. Also doing some work with young carers through Fatima's programme. and also we're linked really well through our Improving Population Health programme to the West Yorkshire Violence Reduction Unit. And we're just about to start a piece of work with women and children in relation to reducing inequalities in violent crime. So there's a kind of health angle, but also the kind of wider sort of determinants angle as well, looking at housing, violent crime and economic recovery as well. So there's some real sort of specifics coming out. I think we need that, obviously, that strategic approach to tie it all together, but then the sort of real specific areas of action. And there was some areas sort of particularly picked up in Friday's letter from NHS England on sort of phase 3 of the recovery from COVID into what we should be looking at as a system as well on health inequalities, and a lot of that sort of within our plans already that we'll pick up.
Yeah, thank you. Do you have any targeted milestones in your review in your paper? I think that was what I was asking as well, because you're saying about a targeted focus. Will there be some targeted milestones that you need to reach?
So we'll set some recommendations as part of the review. So the milestones we've got at the moment, there's 4 review panel meetings over the summer, and then a report will be published in the autumn, which will be sort of signed off by the chair, the independent chair of the panel. So that will set out the sort of recommendations, which I anticipate may have some milestones within it.
Okay, thank you. I wonder if it's possible for us to look at that report when it is available, please, so that we can you know, add any input if we wish to.
Yeah, and just to say as well, the as Fatima said, the first review papers were on the website, and I think the second ones for the second meeting will go on sort of today or tomorrow. So throughout the review, we want to keep it as sort of transparent and encourage as much input as we can get. So all the papers will be sort of public on the website for it as well.
Thank you. That'd be great if you could share the link with us, so that we can just click onto it. That'd be fantastic. We can all have a look at that, and yeah, we would really welcome seeing that report in the autumn and being able to feed into it. So welcome that. Councillor Hutchinson.
Thank you, Chair. I mean, you've bitten off a very large meal to chew in this, and I understand why you need to prioritise. But Fatima was saying that these barriers haven't been intentionally raised, that there are areas where barriers have been raised, and we saw it to tragic effect during the Windrush scandal. And I know that so some of the most deprived of the deprived are the people who have indeterminate right to access the main sweep of health services. I know you're planning to do some, I think sounds like fairly limited work in Leeds with with asylum seekers, but I wondered whether there should really be some work being done on the impact of the restrictions of access to healthcare for people who are who are either put off, frightened of seeking healthcare because of links to the Foreign Office, to the Home Office, or otherwise feel they're excluded. And there is some evidence that people have been put off seeking care for coronavirus symptoms for fear, because of those fears, even though those are covered, you know, they have the right to be treated in the NHS for coronavirus symptoms.
Yeah, I agree completely. A really important sort of population group for us to focus on. The work I kind of touched on in Kirklees was something we funded, but part of that funding, the ask of that is to share the learning across the partnership that we can build on. And I know there's some specific work going on in Calderdale that Robin Tuddenham's sort of linked into as well, and he's linked to some sort of regional groups on refugees and asylum seekers. But I agree, and I think it's something we need to kind of go back and think on in terms of our health inequalities network, what more we could do that population group. So thank you.
I'd really welcome it if you could do that. You know, we've got this, Bradford as a city of sanctuary, Calderdale as a valley of sanctuary. It needs to be more than just words.
Okay, thank you very much. Any more questions for the team? Can I just on this issue, and I really, what you said there, Fatima, earlier about getting comfortable with being uncomfortable. I think it's something that historically we've been quite bad at as a society, really, about having those uncomfortable conversations, and we've needed to do it on a range of issues, and this needs to be, it needs to be happening now. Yeah, in terms of, and also echo what you say about, we use this term BAME, but these are very, very diverse and different communities, and even within the communities, and it's a very catch-all, and I don't know how helpful it is as a kind of you know, an acronym, or and because we're talking about very diverse, you know, communities of people, and individually within those communities as well, very diverse. So but I'm just really kind of I feel reassured and empowered now to hear you two about all the work that is going on, but also that you recognise, as you said, Fatima, that we can say all of that we're doing, but actually, you know, are we having those conversations to see what impact it's having? And we'll really welcome your report in the autumn, and to hear from you again, because this is something that I don't want to go away, that we want to really focus on getting this right. And COVID's just speeded it up, hasn't it, and made it really, really important. So thank you very, very much.
Can I ask a cheeky question, Shah?
Absolutely,
you've got about 30
yes.
seconds left. So as in your individual scrutiny roles back in each of your places, would you be able to ask the question when things come to scrutiny, what representation has there been in decision making for this decision? Because as Fatima said, I've written to everybody asking that they ask themselves and put in place the appropriate measures so that they've got the right voices in the room. And if that was something that you were asking too, that would really help.
Yes. So just to clarify, what question do you want us to ask, and of who?
So say if something comes to scrutiny, it's worth asking, in making the decision and choices here, how have you ensured that there was effective representation during the decision-making process? So you've got people from Black, Asian, minority ethnic communities and others with diverse characteristics being involved in the decision.
I'm fairly certain that all our chairs, and I don't know whether we ask those questions all the time, and not just, you know, if we ask, you know, have the deaf people of, you know, with different disabilities and all those protected characteristics, how have you engaged in them? A question that always gets asked at my scrutiny boards of different is, how many different languages and how many different communities have your communications been? But we will definitely strive to keep asking those questions, and I ask them about on my board does about every consultation, just who has been involved in this consultation. I don't know whether anybody else wants to comment on that of the other chairs. Fatima, did you want to come in there?
It's just a helpful suggestion, if I may, Chair. So I used to be a scrutiny co-optee, as Councillor Smage knows all too well, and I just wonder whether there's something about, in regards to diversity, and how we can, you know, expose people from BAME communities to different opportunities, because one of the things that we found in our work is that lack of exposure to board level or governance level forums like scrutiny. Maybe have of objective of, you know, how many people have you got from BAME backgrounds that are co-optees as well as elected members, because that will support your scrutiny and diversity of thought in the room. It's just a suggestion, you know, feel free to we found it helpful in Kirkley.
Yes, and in terms of working with Health Watch as well, and in terms of we work very closely with Health Watch, but you know, and scrutiny, kind of working with them about the different communities that they work with, and I know that in Leeds they work across the board, and we're hoping that this board will work more closely with Health Watch as well about the representation from the different communities onto Health Watch. But that's a really because in Leeds, we only have one co-optee, and that's from Healthwatch. That's but we do have membership. The membership of our board has got Black and Asian representation from our elected members. But that's a really interesting point, and one that I'll take back to my board in Leeds. Councillor Greenwood and Councillor Smager has to come in as well.
Yeah, it's just a really quick one, actually. We've got a scrutiny meeting in a couple of weeks, and we've got health inequalities on the agenda and a service update as well. And we've made sure that we have got representation from all backgrounds. We've got Dr. John Wright coming, who you may probably know, and a respiratory consultant who works with him, who's from a BAME background. So we have sort of purposely gone out there and made sure that we have got equal representation as much as we possibly can.
Councillor Smage?
Yes, thank you. Yes, we're always asking when we have anything as to what the different communities are that have been reached and how they've done that, etc. But I would also be interested in hearing how they review. You mentioned as well about talking to people in communities, and I would also be interested to hear some information on that work on reaching people to discuss the problems. I think that would be interesting for Scrutiny to hear as well. Thank you.
Do you want me to respond to that now? Oh, sorry, Rob was going to respond.
I was going to say that very happy to do that. Just the thing I was reminding myself, which I might as well say out loud, is that the network of networks which Fatima chairs is made up of networks from local government and the NHS, and is a resource for you if you want to use it. So I think we're very happy to feed into Scrutiny locally and hear any insights or input that you would like.
Yeah, thank you, because I think it's important for Scrutiny to hear from everybody about the different problems that they're having or the good things that are happening. I think it's really important that Scrutiny hears that. Thank you.
Definitely, and I think we've got our next meeting in September, and we're also having an update on what's happening, especially with health inequalities. I know it's a particular passion of a number of us on the board. So utilising the Leeds network would be, BAME network would be fantastic. So I'll look into that. Thank you, Rob and Fatima for raising that, because I think we want more people to be involved in Scrutiny, rather like the more involvement, the better, and having those leaders coming forward would be really valuable. So thank you for that. Right, so can I thank all of you? It's been an absolutely fascinating, quite challenging and scary meeting in some ways. So it's just been brilliant. So thank you all, and thank you to everybody who tuned in to watch, as it were, so which is a bit new for us. Kind of used to it with council meetings, but not with Scrutiny meetings. But just thank you to all our partners for coming in. So have a lovely afternoon. If I could ask members of the board to please stay on the meeting to discuss the work schedule. But thank you very much for your inputs, and we'll look forward to the next meeting and receiving the reports and the different links that we've requested. So thank you very much.
Thanks, everyone.
Councillor Hayden, would it be okay if Ian Holmes stayed for the?
Of course, yeah.
Anybody's welcome.
Anybody can stay. I thought people might want to leave. But absolutely, Ian, you're very welcome. Yes, and it'd be very valuable to have your input on the work schedule. So, do you want to go ahead with that, Mike, now?
Yes, thank you, Chair. I've got a few things to talk about, if I may. But first of all, to say I left the meeting briefly to talk to Councillor Clark on the telephone, who is actually feeling very frustrated by not being able to speak. I'm not quite sure what happened there, because he certainly appeared to be in the meeting, and there was a technical problem. He's asked for two things. One is he'd like to have a conversation with Councillor Hayden which we actually have as an outstanding item to have a conversation with him. He's very keen for North Yorkshire to remain involved in this committee. And he's asked, and perhaps if there is a conversation between Councillor Hayden and Councillor Clark, he's got a particular issue he'd like to have on the agenda in future about the Nightingale Hospital in Harrogate and the future use of it. Right. So I said I would pass that on to onto the committee this afternoon. I just wanted to mention the well, I also want to thank all the NHS people and Sarah and others who came to help us in this meeting this morning. We've had one or two little technical glitches, but by and large, I think it's gone pretty well. And to thank Ian Holmes and colleagues in particular for helping us get the agenda together a few weeks ago. What we agreed, what Councillor Hayden and Ian agreed, they'll correct me if I'm wrong, is to have a further meeting after the development session I'll talk about in a few minutes, to perhaps make sure that the work plan for the year reflects both primarily what the committee wants, but also makes sense for colleagues in the NHS to, you know, in terms of time frame and fitting in with the 5-year strategy and so on. So the plan is to develop a work programme for the rest of the year to come to the meeting that's been arranged, or we're in the process of arranging for late September. Before I get on to the development session, I think one of the benefits of your committee is that, particularly for colleagues in the NHS, they can do things once rather than 5 or 6 times sometimes. I wonder whether the committee would be happy to perhaps send some of the messages, particularly from the last discussion, back to all the scrutiny committees in that we cover, so that what was said about Rob Webster's comments in particular, perhaps, and Fatima's and Sarah's comments get back to each of the 5 scrutiny committees in a 6 scrutiny committees, sorry, in a sort of slightly structured way, and that we can draft that afterwards. And I've also got the action for drafting a letter to the Secretary of State about support for people in isolation. Out of the meeting with Ian Holmes and Rachel and Karen, Rachel Loftus and Karen Coleman, Ian came to suggestion to have a bit of a sort of development session about working together, and Ian has, I think the phrase is, called in a favour with the King's Fund, and we've been really lucky to secure Sally Warren and Richard Humphreys to support us in that work in September. As soon as Sally agreed it, she went on holiday, so she was hoping to write something for us for this meeting, but wasn't able to. I think the aim is to make sure that you as a committee are looking at the right things, and to make sure that the right things are being done at a local level and the right things are being done at a West Yorkshire level, and that we're working as well together, both you as committee members and the key people in the West Yorkshire and Harrogate Health and Care Partnership. So we've got a date proposed or organised for the 8th of September, and we will meet with Sally and Ian and Councillor Hayden to get that structured in the near future. So I suppose, Chair, the question is, are there other things that members would like to suggest for future meetings at this stage, or, you know, and I'm sure they'll be able to email in if they have got suggestions. Thank you, Chair.
Councillor Smage, Liz, did you want to come in on this, or is your hand up?
I'm not sure I didn't lower my hand, I think. My apologies for that.
Not at all.
For that
I'm
slipping etiquette. For that slipping etiquette. Although I did wonder as well if we needed to have something about how the West Yorkshire Partnership was going to support things going forward in the winter in more detail, and on the different strands of their work, how they were moving forward through the winter and into the following year. I wondered if that was a possibility. Thank you.
Thank you. Yeah, we've got winter plans coming the September meeting, and obviously it's going to be very different this year. That's to our Leeds meeting. Ian, did you want to comment on?
Yeah, I mean, to an extent, we're in your hands. I think a conversation about some of the things we touched on today around planned care and cancer later in the year would be helpful. Would be the point where we've got a position against the 70%, 80%, 90% that Councillor Hutchinson was describing. I think it'd be useful to talk about that in a bit more detail when we've done that work. I think the work around Black, Asian, minority, ethnic and inequalities is progressing quickly, but your input and insight into that would be really helpful, I think, as it continues. There's other service areas that we talked about previously, which possibly haven't been getting some of the same profile recently, but which are still important, like maternity services, things like that. So I guess what would be great to do is almost agree that sort of meeting by meeting forward plan, so we can get the right folk along. So I think what we find is when you get the subject matter experts, it's a richer conversation. So if you've got the specific topics and then those conversations and manage it that way, then that would be good. But yeah, certainly the sort of the cancer and planned care stuff, certainly the inequalities and Black, Asian, minority, ethnic, potentially workforce might be useful to discuss again as well.
Well, workforce has been an issue in the past, and this kind of fits into that overall, looking at workforce. And I know that Councillor Hutchinson did a lot of work on the kind of workforce issue, and this fits into this and could be a specific focus.
Yeah.
Colin?
Yeah, certainly. I mean, that kind of came to a halt with the, it was felt that it was not appropriate to draw officers away from the response to the pandemic. So that's kind of run into the sand. There was released the next part of the NHS People Plan last week, and how that's actually incorporated into the local plans would be something I would be very keen to explore, and but also workforce issues, given the likelihood of lots of people losing their jobs, and what the opportunities are for actually trying to entice them into the health and social care workforce by some appropriate strategies would be something I would like to explore.
Yes,
there's a connection, and there's a connection there with some of the devolution work, isn't there, around skills and institutions, and the conversation we've had previously around that sort of virtuous relationship between good economy and good health, which might be useful to get into a little bit there as well.
Definitely. Liz, did you want to come in?
Thank you. I wondered if it was worth having a workforce meeting again that we've had before, because I mean we need to consider both the well-being of everyone, don't we? The well-being of everyone, and the well-being of NHS and care staff. I think moving forward we need to have some information on as well. I'm concerned that if this goes through the winter, the well-being of everybody is, and health of people well, I'm not sure how to put it exactly, but you understand what I mean. It is, the winter is going to be more of a struggle, I think, for many. But if this is ongoing, then the well-being and the health of NHS and care workers is going to be key as well. Yeah,
definitely. Councillor Hutchinson, Colin. Are you muted, Colin?
Sorry, is it acceptable that I try and set up another meeting of the workforce subcommittee, then together with Mike, and find a date that's convenient for members?
Is that okay, Ian?
Yeah, absolutely.
It certainly is with me, and we can do it virtually, so it's quite easy to find a date, isn't it, that we can all, in many ways there's advantages to, apart from Councillor Clark not being able to be heard, but about getting more people in and having a meeting. I think I'd really welcome that. and look at all these issues, because I know that when in Leeds, in terms of the council, we had people who were no longer working at our leisure centres because we closed them, working in residential homes, and we've trained up more people as carers in adult social care, and they've really found that and the feedback that we got from the staff survey was that they realised that their skills were transferable, and really a lot of them really enjoyed working in residential homes and in care, which they'd never considered before. So there are opportunities here, I think. I mean, obviously our leisure centres are reopening. Thankfully, I know that's not the case around other places in West Yorkshire, so apologies about that. But you know, it's taking those opportunities that this situation, as well as a closer partnership working to solve some of those issues that we've been talking about for 2 or 3 years, that we might get solutions to them. Right, that's really. And anybody else want to make a comment? So we'll get a working group set up about workforce and about all the different strands that come into that. And I think and yes, we'll and keep in mind going forward about, I particularly think the cancer and the mental health strands that are, you know, going to be so important going forward. Yeah. And yes, and it's quite exciting about this workshop in September. So thank you to Ian for
and you know, we're genuinely in your hands really in terms of that. You know, as Mike said, we've done a few things for the King's Fund recently, and they were happy to return the favours. It's Sally Warren and Richard Humphreys, who are both excellent folk, really good people who can come and help facilitate it. So, and I think it's about how we make the most of the time that we have. I think the West Yorkshire versus place thing and avoiding duplications important, but I think it's also how do we make sure that we've got the right, you know, productive conversations to you know, so that we, you know, the work that we do is focused in the right way, really.
Yes, definitely. Okay,